Great to be here. Honored to be able to have this conversation that I had inquired about probably 2 years ago, but I'm grateful that 2 years later I learned a lot and I'm still learning. So just want to share some of my knowledge and experience, both lived and expert experience in this field in working with pregnant and parenting people. I first want to start by saying that I live and work on Tlingit land, and I acknowledge the historical injustices faced by Indigenous people and commit to reconciliation, respect, and partnership moving forward. I am located in Sitka, Alaska, and I'm going to go ahead and share my screen because that would help. So Michael's going to be watching the chat, so I will not be able to see it. So if you have any questions or want to say anything as I go through what we're going to go through, please feel free to raise your hand, or like I said, put it in the chat and Michael will let me know. My name is Michelle Kavouras. I am currently living in Sitka, Alaska. I just moved here 9 months ago from Illinois. Currently a program manager for a residential program, and will be starting as the prevention program manager in 2 weeks. So just passionate about helping people, working and advocating, and also.
Oh, I'm sorry. I just muted you. I meant to I meant to bring somebody in and I hit and it moved. I'm sorry.
Already, that was early. No worries. So a little bit about my own experience. I had my son, Max, 15 years ago. I was using substances and had an adoptive family picked out for him that I selected a month before I had him because of fear of even considering all the options and not having any guidance through that. And when I had Max, he was with me the first night in the hospital room, and then the doctors came in, or the nurses came in the morning and removed him. And I wasn't really sure what was going on. I've had children before, and usually they'll take them and go check the baby out and bring him back. They didn't bring him back. A few minutes later, the doctor came in and started screaming at me and telling me that basically I was pathetic and how can I do this to my baby, and all the things I already knew about myself and about, or I thought about myself, and just asked him to leave the room, which he did. However, the rest of my stay there at that hospital was pretty traumatic, and I didn't ever really think about advocating on that piece until fast forward to 8 years later. I started my path to recovery and started working in treatment centers, and that didn't really fulfill my piece. So I started working in a harm reduction organization where I was asked to get on a platform where we were presenting to a bunch of doctors, 150 doctors to be exact. And it was a virtual platform, and I was able to share some of the experience I had seen in working with participants and how traumatizing that was for the participants and myself, and how reporting people because they're on methadone or Suboxone to me just made no sense. And I expressed that in that presentation, where some of the doctors didn't like what I had to say, and they filed a grievance against our entire presentation, specifically what I had to say about mandated reporting, which I was terrified because I was literally being yelled at in this presentation in front of a bunch of doctors, which I was already intimidated by, and thought I was going to lose my job. But what ended up happening was the doctor that actually asked us to come present eventually offered me a role as a doula. So I was able to share my experience in that space, and haven't looked back. It's been an honor to do that, but also hard work. So that's a little bit about me. And we're going to get into what we're doing here today. So I would love it. I mean, how many people do we have? I think 22. So if you would like to come off mute, please raise your hand and we'll go through. But if you can introduce yourself, if you don't want to come off mute, feel free to put it in the chat. Your name, what state you're living or working in, what is your role, and what is your favorite live event you ever attended? It could be a concert, comedy, community events, just a little bit to get to know each other here. Sean. Let me see if I
I'm originally from England, but I volunteer at CCAR New Haven, Connecticut. And favorite live event, when I first came to the States, I was able to go to the World Cup. So that was, I think, in 1994. So I'm giving my age a little bit there.
Oh, cool. Thank you for sharing. Safia, did I say that right?
Yes, you did. As good as it gets, right? So my name is, hi everyone, my name is Safia Al-Mashari. I am half American, half Qatari. I'm from Colorado. Let's see, I live in Qatar. I'm divorced with 2 kids. I work in a rehabilitation center, a one-of-a-kind facility in the region. And I recently got certified as a recovery coach. An absolute amazing path. Thank you so much, Michelle, for sharing your story. It was very touching and inspiring. And yeah, anything else that I'm missing?
I think you're good. Thank you so much.
Okay, you're welcome. Thank you.
Oh, I muted you. Sorry. Try that again.
There we go. Hey, I told you I'd be here, Michelle, cheering you on.
Yes, you did.
So I'm
see you.
Nika. I'm an RCP and RCPF in England. I am so glad to see Safia here, and hopefully I'll get to see her again in Qatar soon. I'm a mama of a daughter in recovery, and just really touches me, this topic, because I became a grandma raising a grandchild, when and just everything that happened. He came into my life he was about 2.5, but the problems were going on long before I could see him, even though I have my own personal recovery journey. So, and I just know in England, this is not something that we talk about very much at all. So I just want to learn from you. And the best live event I went to, I got to see the Foo Fighters in a little tiny outside stadium on some grass in Texas. And it was phenomenal, because in England, they only ever perform at huge stadiums. And no, I felt like Dave Grohl was just singing to me. It was fabulous.
That's awesome. Awesome. Love it. Thank you. All right, Katrina. I'll let Mike unmute so I don't mute you.
Sorry, my phone is going off. My name is Katrina. I am a peer recovery coach office manager at Peer Connect in Colorado Springs. We are opening a Denver office, and we have one in Loveland as well. It's really exciting to be part of that growth. But I stay really busy doing it. This subject is very important to me because I have a 2-year-old, and I was homeless for 3 years before I got pregnant. In the last year of it, I was pregnant. It was the most hardest pregnancy and the hardest time I ever did on the streets. And this time my parents didn't enable me. So I actually had to get everything together. So she has been clean for 2.5 years, and I changed my life. I got her back in my life, and very ostracized in the hospital when they took her from me. They didn't even tell me they were sending her home with a foster family 2 days early, and being left out of her release from the hospital when she was a newborn was very devastating. But it was also part of the guiding principle of what led me to finally getting everything together and getting into this field of work and giving back. And I would have to say my favorite live event I've ever attended, it was actually a Krikna that I went to, which is a gathering of NA, and they come together at Halloween. And the guest speaker had the most powerful speech when he asked how many years clean people had, and they did a countdown. And when they got to the part about the person who only had less than 30 minutes clean was the most important person in the room, and we all needed to be there for them. That was a very touching moment in my life. So I'm really glad you are doing this presentation, and you have a great story, and thank you for sharing it.
Yeah, I'm glad you're here and thanks for sharing that. It's important that we talk about it because it's real, it happens. Thanks. Raquel.
Oh, sorry. I was trying to
You're
change
good.
my name there. I apologize. I just realized that it didn't have my name.
I know who you are.
Thank you. I'm so glad to be here. My name is Brandy Anderson Willis. I am in Indiana, and currently my role, I am the founder of a nonprofit organization where I have a team of coaches and supervisors on my teams. And this touches my favorite live event I've ever attended. Um, Goodness, that is a great question. If it doesn't have to be anything business related, I would say that I went to my first concert last year in Indianapolis after Black Expo. So that was like one of my favorite all time. It was some throwback artists that were presenting. So that was really awesome. So that's probably what comes to the top of my mind.
Nice. Thank you for sharing. McKaylee, is it?
Yeah, that's right.
Very good.
My name's McKaylee. Yeah. I usually just go by Kaylee because a lot of times it looks weird and people like to say Michaela when the first part's added to my name. But I am a certified peer recovery coach in Indiana, and my current role is with our local hospital, St. Elizabeth. I work with new and expecting moms in recovery, which so far is great. I'm like super excited about that. Um, and I'm a mom of 5. I just actually had twins in February, which was kind of cool. My best birthing experience so far. Actually, not so far. That's it. That's all. There's no more kids. And then probably my favorite live event was once the only time I've never been to a concert or anything like that, but one time I went to a NFL game with the Indianapolis Colts and the Seattle Seahawks, and it was so cool. So, but I'm
Nice.
happy to be here.
Yeah, welcome. And thanks for the work that you do.
Thank you.
Seriously, I know how hard it is. So,
Yeah.
all right, we have some people that introduce themselves in the chat. Let's see. We got Ashley from Vermont, peer recovery coach, Heather from Vermont, Tegan, yay. I know Tegan, I used to work with Tegan in Illinois. From Taylor Swift, I should have guessed that. Angela, a recovery coach from Colorado Springs. Amanda from New Jersey, works at the Center for Prevention and Counseling in Sussex County as a recovery coach. Music Fests from Heather. Michael is in Connecticut, and his favorite event is MPRC. Mike, what is MPRC?
Multiple Pathways of Recovery
Okay.
Conference.
We use a lot of, letters here. So just to clarify, I'm Melissa from Texas, opening a PPR house and providing services to moms. That's amazing. Sean Weir, RSS Mindful Responder, yoga therapy, therapeutic yoga meditation, nature practices, recovery coaching, veterans, responders, recovery, underserved communities. How do you sleep? And Siobhan's listening. So Julie in Maine, peer recovery coach for women, many who are pregnant and or mothers. And Samuel from Colorado Springs, recovery coach, peer connect. Thank you everyone for introducing yourselves. My favorite concert of all time, or my favorite live event, was Mumford and Sons at the Aragon Ballroom. That was amazing. I would love to see them at Red Rocks, though. That's one of my life goals. Hopefully they play there again and I can afford it, because I definitely couldn't afford the last one, and nor did I pay for it. So, all right, we will get into our objectives. So, objectives. understanding that using drugs does not mean you are incapable of parenting. And I'm going to read that again. Understand that using drugs does not mean you are incapable of parenting. We're going to talk about best practices when working with pregnant and parenting people who have or are currently using substances, according to my experiences. Awareness of our own biases, some case studies. Hopefully I can get through 2 of them. I definitely will hit on one, but then I have another one at the end that I want you all to think about, a scenario that maybe we can go over and kind of role play. And then how to navigate all of this with our participants. Any questions about the objectives? Okay, so we're going to have some working agreements so that we can make sure that this space is safe for all of us. It is being recorded and will be shared, so keep that in mind, but also I want us to have real conversations and I want it to be safe. So if anybody has any working agreements, for instance, make it a safe space. And one of the things that I want to also say is that if you need to take a break and step away, feel free, do that. Take care of yourself through this, because we're going to talk about some stuff that might be hard, you might not agree with, or you might feel re-traumatized by, right? So in this work, that's my story a lot of the times, is reliving through some things. So does anybody have any suggestions about things that we can do for working agreements or things that you would like to see in this space?
No question is a silly question. Be brave enough to ask it.
Yes.
I admire
Um,
every single one for sharing their story.
We want to make it safe for people to share. And I think a good one is to be vulnerable, but also making sure that you're safe in that space. Anybody have anything, like no distractions on camera? If you are moving around a lot, maybe turn off your camera just so it's not distracting. No? Okay. Feel free to put it in the chat too if you have anything that you want to, or comes up for you at any time. We can come back to that. All right, so one of the things that I thought was important to share was a report that Dr. Nora Valco shared in a research project she did. And I'm going to quote her on overdose deaths that increased in pregnant and postpartum women from early 2018 to late 2021. And I think what she said was really important. So I wanted to highlight that. And I also want to let you all know that all the slides that I'm showing you have links embedded in them. So we can share all the slides and then all the resources that you want to see if you want to read the entire research project or any of the things that I share. It's all going to be here. So the stigma and punitive policies that burden pregnant women with substance use disorder increase overdose risk by making it harder to access life-saving treatment and resources. Reducing barriers and the stigma that surrounds addiction can open the door for pregnant individuals to seek and receive evidence-based treatment and social support to sustain their health as well as their child's health. I think a lot of times what I've seen is that in the healthcare system, we forget about the parent. We are so focused on the baby or the children that we forget about the parents. And I really would love it if we could reframe that for our healthcare system providers and social workers and child protective services. So along with this, I just released in May of 2024, Biden-Harris administration announced Maternal Mental Health Task Force National Strategy to Improve Maternal Mental Health Care. So in this, which I hope, can you all see what I'm sharing now? It's the Biden-Harris administration. Can you see that? Okay. It talks about what their plans are for this, but one of the things that I thought was really cool in here is the National Maternal Mental Health Hotline. I actually called it pretending that I was a pregnant person who was using substances and I wanted help. And I asked if they were going to report me, and their answer was no, we're just here to help you, which I thought was phenomenal. So then I identified who I was and asked them what resources they had, specifically in Alaska, because that's where I'm at right now. And they did share some resources that were national and not specific to my space. I was able to also share some of the resources I had, which are some of the ones that we're going to go over today. So highly suggest y'all look into that too for the people that you're serving, because, you know, as coaches, as healthcare workers, we're not always available and they need other options. And realistically, like as a doula, I would only see the people I was working with maybe an hour a week or a month, maybe. So what are they doing outside of that time? Who's their supports? So I wanted to share that. So our recovery CCAR approach includes recovery capital, and I'm going to go through what we use for a plan of safe care, which will outline that for pregnant or parenting people, and some resources that we have ourselves. And what does our resource list look like? Is it inclusive of all things that could come up for somebody? And are we constantly adding to our own resource list and building upon that and sharing it with all the people that work, or maybe touching the lives of the people that we're working with? I'm a sharer. I will share any resources I have, because, you know, the more people that have access to those things, the better we can do. And always keeping autonomy of the person that we're working with at the forefront. This is their life, their children, their family, their recovery, whatever that looks like for them. When I talk about motivational interviewing, I like to point out that it should not be manipulational interviewing. So if you're using motivational interviewing to find out information about somebody so that you can use that against them, then you should not be in this field. I said what I said. Stigma and labels. So I'm pretty sure that's self-explanatory to this group from seeing who you all are and where you're from. Stages of change and stages of recovery, finding out where the person is. If they have no desire to change anything, how can we assist them in improving whatever it is their goals are to have a happy, healthy life, no matter what that might look like for them. It's not up to us to decide that for them. And then understanding multiple pathways of recovery. When I first started this work, I only knew of two. I knew AA and NA, and that was it. Since then, I've opened my mind and my heart to all things that I can find to help the people that I'm working with. Not everybody can connect in those spaces and deserve options. People deserve options. So some of the benefits of coaching in pregnancy. So how many people here, and you can raise your hand, how many of you work with participants who have children or are pregnant or could become pregnant? Probably why we're all here today, right? Because we want to learn how to navigate some of the things. I haven't seen trainings that cover this, so I'm really passionate about sharing what I know and learning from all of you too, because I'm sure you all have so much to add to this as well. So we know that holistic and empathetic approach to people with substance use or mental health issues can be super helpful in those spaces, and especially when they're caregivers, especially pre or postpartum. You know, we see a lot of postpartum depression, and especially when children are removed from their care. So making sure that we provide wraparound services and connection and trust and all the things that the people deserve. We all deserve. And the family stability, I've seen so much racism when it comes to child protective services and children being removed. And I've researched, tried to find data around that so that I could share that here, but there really isn't any, go figure. And I think it's really important to say that and acknowledge it, and also call people in to find out why that is. And we're going to talk a little bit about that, working with child protective services, because we know they're not going anywhere. And we need to be the support that helps them do their jobs better, more effectively, and safely for everybody. Pregnant people who use drugs deserve access to services and high quality evidence-based care. So I'm gonna go into this pregnancy and substance use harm reduction toolkit that was created by National Harm Reduction Coalition and the Academy of Perinatal Harm Reduction. And it has been something that I share with any healthcare providers, any social workers, any child protective workers, anybody at the front desk of a place where somebody might come in that they might not understand how to handle situations because of their own biases. But it's a great toolkit, more so for the person that is pregnant or parenting. It outlines so many great things, and I wish I had more time to go through all of it. So I'm just going to share the basics, but it includes it's in different languages. It is specific to where you want to be. So if you wanted to implement something like this in your space, the original toolkit was created in New York. So there was a lot of resources specific to New York. So when I worked at PCC Wellness, we decided to implement one into Illinois specific. So we were able to work alongside the Academy of Perinatal Harm Reduction and create our own, and in our space more appropriate for the people that we were working with in that community. So but it has like all the contents and how to use the materials, and just so many great resources for educational purposes for the person that we're working with, but also for healthcare workers, for them to be able to understand more. And it's all right here. There's also some worksheets that the person that is pregnant or parenting can use. Whatever works for them, right? Some people like to journal, some don't. So finding out what our person is needing and how they can be most effective in their own care. Talks about drug interactions, and then there's some videos too on how to use this toolkit. So the introduction to it, if you're a birth worker, if you were a program on the ground, some great information, resources, and the people behind all this are just amazing to work with. So that's some notes. Any questions about that? Again, it'll be accessible in the slides too. I'll share all this.
I think Yvonne has her hand up.
Oh, I'm sorry, Vaughn. Go ahead.
Michael,
Hello.
I think
Hello,
you're
sorry,
there.
sorry. I meant to lower it. You asked us to raise our hands for something, and I didn't lower it, so I'm very sorry. I'll lower it now.
No worries. No worries. All right, so I'm going to talk a little bit about our plan of safe care. So this is something that when I was at the chemical dependency clinic working as a peer doula, we pulled off the internet, and we didn't like the words in it, so we made our own. And this is something that, again, I will share and you can customize for the population that you're serving. So what this is, it's 6 pages. Ours is 6 pages. The first page really just talks about what the plan of safe care is, but it's really recovery capital. So what that person has already acquired, who their resources are, and it covers all these things. There's pregnancy safe care plan, their needs assessment, relapse prevention plan, and postpartum plan, resources, and documentation I will talk about, because I think that's a really important piece that a lot of people don't necessarily ensure that happens. And we're about protecting ourselves and making sure that we're prepared for whatever might come. So let me get on that. So this is our plan of safe care that we used in Illinois. Talks about what it is. Family and primary contacts are just like the basics: emergency contact, folks who lives in the home, who are the other children if you have in the home. And then the pregnancy safe care plan. So who's their prenatal provider, who's their, if they're on Suboxone or methadone, who's their doctor, and then who's their other supports, their cheerleaders, their people that have witnessed their character and are able to advocate for them as well. Where they plan to have their baby, which we all know that sometimes our plans are not what happens, but where they would like to have their baby, if they want a doula, if they don't have one, can we help them acquire one? A lot of states now, public aid will cover that. So we'll find out if that's happening in your space, and who they would like at the support at the birth. So if they want you there, like, let's have that conversation. What does that look like? How can I support you in that and be efficient and advocate for you, but also keeping it safe, right? Because sometimes if we push too hard, then care gets worse. So understanding all of that, and then making sure that they have a plan for when they do bring baby home. Do they have a safe living environment? Do they have a safe sleep environment for baby? Do they have a car seat to take baby home in? Because you're not going to be able to do that if you don't. And then also getting pediatric care set up before they leave the hospital. I know in Illinois, you could not leave the hospital without having an appointment set up for your baby. This is probably the most effective worksheet on here for me, starting work with somebody. So what are the things that they have and what are the things that they need? So if they have food stamps, if they have transportation, if they have income, if they have an attorney, and if they don't, then that gives me a good space to start with them on what things we need to acquire for them. So it's really helpful to get an idea of what recovery capital they already have, what they already have been through, because people come to us with all kinds of resources. I learn more from the people that I work with than I do from, classes and books and stuff. So the relapse prevention and postpartum safe care plan is really for them to make a plan. If they acknowledge some of the things that are stressors for them and how to address them, then they're already ahead of the game when they happen. The stressors are going to come, things are going to happen. They're going to be most likely treated by somebody, whether it's the front desk receptionist, a doctor, a nurse, a midwife. Somebody is going to make them feel unsafe. And like, how do we deal with those things? Because I already beat myself up so bad when I went and had Max, that every word that doctor who was screaming at me, everything he said just solidified my beliefs about myself. And what I really needed was support in those moments. So what are their biggest challenges and triggers? What are some things that they can do in the event that they're starting to have unsafe feelings for themselves or their baby? Who can they call? And if they do return to use, what's the plan for baby or their children? Do they have a safe person that they can call to say, hey, I need some help today. Can you take my kids for a few hours? Who's that safe person? Do they have that safe person? Can we find them that person so they can make sure that the children are safe? Because we do care about the children. This is not about not reporting ever, right? It's about just keeping everybody safe, but also making sure that they get the appropriate care and support that they deserve. Everyone. So then on ours, we had specific to Illinois, some resources, but also some national supports for people to call. 988 being one of the newer ones, right? So any questions about the plan of safe care? Does anybody use anything similar to that in their stays? I think this can be used either for the participant that we're working with to share with, say, if child support or child protective services does get called, they can share some of this and be like, look, I have all these people behind me, and I've witnessed where it can affect things to become more positive than if they didn't have all those things behind them and resources. Yes, you are going to have access to all the materials, absolutely. So in Illinois, they aren't required to acknowledge our plan of safe care, and they're actually working towards changing those laws so that Child Protective Services has to acknowledge it. But like I said, they don't have to share all 6 pages. They can share page 1 and 2 and 3 and leave it at that, and just have the relapse prevention plan for themselves, right? Because like, I don't know if that would be helpful if they said, if I plan to use, that could be misconstrued and used against them. So we want to make sure that doesn't happen and that they understand that. So I'm going to ask all of you if you can share some things that you would think would be unique challenges for pregnant parents and people in getting the care that they deserve. So either raise your hand or put it in the chat. There you go.
Thank you. I'm going to go from personal experiences and also from what we are seeing. Sometimes it's hard for us. I was a teen mom when I got pregnant at 15. And that was probably also very hard for my parents. I think sometimes just being scared to tell someone, or maybe depending on what type of relationship or living situation, or maybe your family is very, religious. I know that has also been a barrier for a lot of us, including myself, to be able to be honest about maybe what you've done wrong or what has happened. And sometimes people don't even know they're pregnant. I just feel like sometimes it's even knowing. But I feel like that all of those things could be challenges for folks, just not knowing, being afraid of what someone might say, or depending on what the religious beliefs or cultures are in the family, that can make it difficult.
Absolutely. Thank you. Thanks for sharing. I see Julie said poorly informed doctors who don't understand addictions and MAT. We have, yes, Bob said feeling guilty and shameful. Shame, stigma, and ignorance, fearing not being listened to with empathy. Absolutely. All the above. I had some too. Stigma, right? Which one? Oh, Cynthia, go ahead. Oh, that's amazing. There you go.
I think I can share a unique experience. Can you hear me?
Yes.
Okay, so yeah, I'm working in Qatar in this field, or watching this field basically evolve from nothing to what it is now, and still we have so many challenges. I think our biggest challenge right now is stigma, overall stigma, the whole idea of addiction, where I come from, and in the region, and I think that it's a very, very important topic. That's why I was very intrigued and interested in seeing where the States is with, pregnancy and addiction and parenting and addiction and stuff, because I think that's going to be one of the challenges that has not even come to a head yet, or even noted, because of how newly addiction in general is in the region. So that's just coming from my the other side of the world, our input on it. But thank you.
Absolutely. Cultural factors, right? Absolutely. Julie. I think, yep, you're good.
There you go. I was thinking I just really appreciated that your recovery capital checklist that you just shared with us. And the reason why I was so drawn to that is because by the time I meet a recovery, they are so sort of discouraged, and I'll say defensive, because many have had a history of incarceration, dealings with DHHS. And so there's like this fear and even barrier to me. And I really love that checklist because it takes, it's not value laden. It's just, but it's very direct and honest and open. And I just see the possibility of having some really like productive, wonderful conversations in the early stages of working with the recovery by using that checklist. So I really thank you for designing that. I'm always like, just love finding really cool stuff. So thank you so much.
Saying that, and it wasn't just me. I have to give credit to Samantha Shea and Eva Muskowitz, who was partners in crime at PCC. They actually were huge in customizing and creating that. So I hope you all have a Sammy and Eva in your space that can help you build that, because it takes villages, right? Katrina. There you go.
So one unique challenge that I've seen, and it's actually pretty commonplace, if we have a pregnant female and they're sleeping in the car with their boyfriend, and we know there's tons of resources for pregnant women and lots of houses that will take them and programs they can get into. And it's really challenging when they don't want to come out of the relationship that they have and be independent or work on their own self to put the baby first. Or even once they have the child, they would rather struggle with somebody than make the move into letting go of the relationship or having the relationship like during the day and then sleeping in separate rooms with a child, that's been a challenge that I've had a few times actually, when the female does not want to let go of the baby's dad. And it's really hard to watch that as a recovery coach, and just to continue encouraging them to, try to think differently and plant seeds and let them come to the decision. So that's another challenge that you may also get working with pregnant women or women with children, is the toxic relationship they might be tied to as well.
Thanks for bringing that up too. I've seen a lot of things, right? I've seen, we had a pregnant person that was not wanting to go into the shelter that we were trying to navigate them to, and they declined. And when Dr. Ruchi Fitzgerald, who brought me into this work, she had asked me, she's like, Michelle, what do you think the reason is that they won't do this? And I was like, because the rules, the barriers, the expectations of going into a recovery home or shelter or whatever are not realistic for this person in their life and what they're doing. They may be nurturing a relationship that is important to them, and that's important to them. And we have to respect that, whether or not we view it as toxic or however our bias, right, comes into play. Or we may not think it's safe for them, and being able to build that trust with them to have those conversations is important, but it also shouldn't come with the expectation that we're going to change anything for them, right? I've been through toxic relationships, 12 years. I was in the same toxic relationship, and there was no talking to me about anything, because I knew love was love for me, and that's all I wanted, was to feel that love, whether or not it was healthy for me or not. So yeah, but it's a navigation that we have to accept what their autonomy is over their lives, right? And help them make that as painless as possible for them. So thank you for bringing that up. Super important. So yeah, and all the things too on here. Legal issues, fear of family separation. That's one of the biggest ones that for me, I've seen where people aren't going to come get healthcare if they think you're going to rip their family apart. It's just not going to happen. So if we start building this around us where people understand that it's safe, but it actually has to be safe, right? Like we can't feel like we're safe, but then the person next to us reports them. Like we have to really restructure everything. So, and it starts with us and the people that we come into contact that affect the people that we're working with. So, all right, we're going to go into a little case study, and I would love input from all of you. So this is an actual scenario that I was in, a case. Names have been changed, obviously. So we have Heather. She's a 28-year-old mother to a 4-year-old daughter, Hannah. Heather's been consistently attending her appointments at the chemical dependency clinic for the past 2 years, where she's been receiving treatment for substance use disorder. She's been prescribed Suboxone as part of her medication-assisted recovery program. Heather asked if we would meet her at her appointment today. Absolutely, I will be there, right? So when we show up at the clinic to support Heather, we realize she's under the influence. Heather had brought Hannah with her for her checkup appointment. So the part where I want to hear from you guys is some questions that I want you to consider. So what are the first things that come up for you? And you can put it in the chat or raise your hand. Fine, go ahead.
I would think it depends on the state and jurisdiction, what your policies and practices are. Like in Connecticut, from my understanding, recovery coaches aren't mandated reported, so we don't have that. But some jurisdictions, you may be a mandated reporter. So I guess that's one of the big first questions. It would depend on how you proceed, maybe.
Sure. Katrina asked, is she honest with us about using, or do we just see that she used? So it wasn't like a forthcoming conversation. It was something that we had to build up to have that conversation, but it was apparent. It was apparent. I also, well, we'll talk about what I did, but okay. The next question, what is our understanding of mandated reporting? Sean, you talked about that. Some of us are, some of us aren't. Some of us have multiple roles. So I'm a counselor. I'm a mandated reporter. I'm non-mandated supporter. So how can we apply our skills to assist both Heather and Hannah? Anybody want to talk about that? I got Ashley said, try to find out if there's anyone who can take Hannah for a few hours and help transport them so they could be safe environment at that time. I love that. Thanks, Ashley. Anybody else want to chime in? And Brandy said that's what came up for me, even if it's an employee. Oh, I'm sorry, I missed. Try to find out if there's anyone who can take, yeah. In the UK, professionals are obligated to report safeguarding concerns. A consideration would therefore be if Heather is capable or safely looking after her child. Yes, thank you. Sean, is your hand raised again, or did you just not unraise it?
No, I just didn't take it down. But if let's just say, if I'm just in the role of the recovery coach, and then bringing the awareness and for the safety, as opposed to mandating. If I'm just playing the role as a recovery coach and bringing, asking good questions, how does she, if I can, depending on the state of consciousness, that would be what would be coming to mind. Using the three-legged stool principle, asking good questions. If she's in resource, but can she make those informed decisions if she is under the influence?
Yeah. I think. Okay.
Sorry. One thing that comes to my mind as a recovery coach, if Heather was to call me up and ask me to meet her at her appointment, and then when I show up, I find out that she's under the influence and her daughter's with her. One thing that would come to my mind as a recovery coach is at least there is that secure trust connection between me and Heather, from a recovery coach to a recovery, enough for her to perhaps call me up to know that she's not in a safe environment and she needs that support. So I would, as a recovery coach, be very happy to see that she's reached out to me, possibly in a indirect way. So it would actually help me assess the next seating with her and to how, like, what made her fall into this emotional state of Heather. And if this does occur again, she needs to be more clear so that at least before she actually drives with her child to the appointment, then I would actually say, okay, leave your child home. Let's find somebody that can care for your child. And then I'll come to you. We can meet up, or I can come and get you, so kind of taking it a step backwards. So for when I look at it as a recovery coach, that those are the things that come in my mind.
Yeah, and all very important, right? This is something going on in your life, like, and her trusting you and celebrating that she showed up and that she's willing to, continue her care for herself and her child, because Hannah was there for her appointment as well. Thank you. Thank you for sharing all that. If I can unmute you. There you go.
So I think, like, in total recovery coach head, I'd kind of celebrate her for making it to the appointment, celebrate the fact that she called and asked me to be there. And then I'd kind of asked her, what does she think we should do about the situation, or what does she need in order to keep them both safe, Because when we treat people like a resource, she might say, call my mom, call my sister, whatever. Yeah. And I think it's just, yeah, I mean, I've been in a situation last year around this, and I struggled with it a lot. So this is something that's, yeah, really interesting, a bit challenging at times, but I'm open to go through that and see how I manage it. But yeah, I just think if people show up and are willing to do something, just give them the chance to have the answer too, because they might know that next step, even if I don't.
So we have, let me move the chat. I think I got everything. Insurance safety. But are not so good. Who are affecting her willingness and readiness to recovery. I would ask if anything's happened that she's worried about. Okay. And then they agreed with you. So, all right. I am going to share my response to this. So we didn't break up, but that's okay. So what happened for me in that space? Yes, I celebrated that she showed up to her appointment. Huge win, right? Because I know how hard that is and how scary that is. And I told her that. After assessing the situation, I had checked in with my team, the doctor, the nurse, the social worker. And we talked about mandated reporting and what are our requirements, and do we have to check with the front desk lady who obviously has seen the situation as well, because she had to check in and make sure that we're all on the same page on what to do moving forward. I did talk to her. I talked to Heather and asked her, you know, how did you get here today? Because I knew she took the subway. I knew that her condition being that she was nodding, I didn't feel like that was safe for her to be on a subway with her 4-year-old, obviously. So I had asked her and I told her that I was honest with her and told her that I was concerned, and I asked her how she got there today, and she said her father brought her. And I said, okay, where is he? And she said he was out in the car. And I was like, would you mind getting him just so I can check in with him and make sure that everybody's safe? Because that's my job. I need to make sure that you're safe and your daughter's safe. And I just want to make sure that you have this plan, right? Her plan was to have her dad. So he came in, I met with dad. He confirmed that he was caring for Hannah until Heather was able to. And I also offered him some support for, I'm a craft trainer, so community reinforcement and family training. I'm trained in that. So although I wouldn't work with dad, I could link him up with some support and resources of something that would be beneficial to him. And also, you know, there wasn't a whole lot more that I could do in that moment with Heather because she was not really engaged in conversation so much. But she did continue to come for care. You know, I did also tell her dad that I could never discuss anything about Heather or Hannah with him without a release of information signed by her. And when she reached out a couple weeks later, she did tell me how shameful she felt and how embarrassed she was. And I just always met her with compassion and never judged any of it, just celebrated that she came in, celebrated that she was bringing her daughter for her appointment. We also had one of the doctors evaluate her to make sure that she was safe, right? In that moment, and her daughter got checked out too. So everybody was okay and safe, and they went home. And like I said, she was checking in, and I reiterated the fact of how hard it is, I know, to walk in the doors, and being able to do that is she, as far as I know, when I left Illinois, she's still maintaining her recovery, whatever that means for her, and thriving in life. So I think had things gone differently, and as I was taught when I got onboarded at the hospital in the chemical dependency clinic, they told me if I'm ever in doubt to call DCFS, Child Protective Services. And I challenged that in the training as I was onboarding for my new role. Like, wait, maybe that's not the best answer. Maybe it's to get with your team and discuss it as a team and decide on what the best outcome, best chance of a positive outcome could be. So, all right. So we're going to go ahead and take a 10-minute break and come back. So if you guys go stretch or some more coffee, I'm going to get more coffee. But thank you all for that great conversation about that. And it's only the beginning, right? Thanks. All right, welcome back, everybody. I hope you got to take a nice little break and stretch. I'm going to jump right in just because I'm a little behind on my time. So I don't know. Hi, Jacqueline. So happy you're here. I don't know if we'll be able to do the role play exercise, or I'm going to try to squeeze it in because I would love to hear from all of you what you're seeing. So mandated reporting. Let's jump into this. So understanding what your requirements are if you're a mandated reporter. Also how that involves you in how we can be effective if that decision has to be made, right? I'm going to talk about the Child Abuse Prevention and Treatment Act, otherwise known as CAPTA, and what the requirements are that were updated in March. So this is something that's been around since 1974, and I'm so happy that they update it. And I just hope that we can implement that in the spaces where it needs to be implemented, right, in the healthcare system. So I'm going to share with you what that looks like. And this is through If When How's website that I found what they have for the requirements of healthcare workers. So it talks about what this fact sheet entails and who it's for. Again, for healthcare workers, so doctors, nurses, and people who are providing the services to the people that we work with. And if we understand this, then we can be more effective in empowering the people that we serve and able to advocate for them and hold people accountable. Now, that is not to say that hospitals don't have their own requirements that may not be updated regularly, right? Even where I worked at the chemical dependency clinic, I experienced that their rules and guidelines were very different than what we had in the chemical dependency clinic that resided inside of the hospital. So, but this is a great resource for anybody that works with people. So it talks about each state's requirements. So for Alabama example, drug test on a pregnant or birthing parent is not required by law. My understanding when I had Max 15 years ago was that I'm going to get tested. He's going to get tested. There's no way around it. It is not required by law. So knowing that, I mean, it might have changed some of the way that I don't think it would change anything actually in that situation because I was so discriminated against and treated unfairly and poorly. So, but this is, like I said, as of March of this year. So, if screening does indicate a need for a drug test, providers should ask for and get informed consent prior to drug testing a pregnant or birthing parents. Drug test of a newborn is not required by law. If a newborn is drug tested and result is positive, a child abuse or neglect report is not required by law. So this is just in Alabama and Alaska where I'm at. So it breaks down like what the requirements are today. And knowing that healthcare workers, some of our healthcare workers have been doing this for years and don't require specific trainings on updating their information and policies. So I think this is a great place if you have it in your bandwidth to be able to advocate on behalf of people, but also just letting them know that these are their rights. So that resource is also going to be available to anybody that we send the slides to. And if you want it, you can reach out to me personally and I'll send it to you. I have no problem sharing. I think the biggest thing to take away from this is reframing mandated reporting to mandated supporting. That's what we all should be doing. That's what all the healthcare providers should be doing. That's the oath that they took to get into the role of social workers, child protective care workers. I really don't believe that they get into the work because they want to harm anybody. I think they really want to protect the children, but they also need to understand that means protecting the family and providing appropriate care and resources. So, reporting obligations, understanding who you're reporting to. It's really tricky when we think about how child protective services workers are, how they're working, their culture in their spaces, and a lot of them are overworked. There's a lot of turnover in that space. I can only imagine. I could never do that job. I just think I could never do that job. There's just too much misinformation when I see a child protective worker that doesn't know anything about substance use or mental health, and they're put into these spaces that they shouldn't be in. It's not safe for them, and it's not safe for the people that they're working with. So just understanding that and knowing that, you know, we make this call, we think it's going to actually help somebody. So we really need to know that that's what is going to happen, know what the outcomes could be in those situations. Also knowing the requirements of the healthcare system, like I said, what is the social worker at the hospital where they're delivering? What is their requirements? What are their biases? What do they understand? Do they understand about substance use? Do they look at it as if person has substance use disorder means they're unfit parent, right? Like, that's what I've seen, and that's not what it should be. Also, what does the foster care system look like? So we make this call, we make this decision to make this call, and this child gets removed from their parents' care. Where are they going to go? What does that look like? Is that safe? In Illinois, I was a foster mom, and I knew foster parents that shouldn't have been anywhere near children, and they were licensed to do it. So like knowing what that looks like, what the outcomes could be, and if you have that in your bandwidth to advocate for change. Again, they're overworked, understaffed, traumatized. They see some stuff, right? They're stressed. So meeting them where they're at. Again, like I said, we're not gonna get rid of any system that isn't working. So how can we be effective in empowering them to do better? And when I talk about understanding what CPS culture is, I mean, wherever you're at. So I came from Illinois, working in a hospital on the west side of Chicago. It looks way different here in Alaska, way different. And I have to fully understand what that looks like. So if I'm over here advocating for people not to make calls, sometimes those calls are the only connection that people in certain communities will have to outside sources. So I really have to weigh the pros and cons of making a call. Is it going to be helpful for that family to be connected to services? And how can I strengthen those services that they're getting? Can I work alongside the Child Protective Services workers? I think we have two here. I don't know. I'm in Sitka. I'm in a little town of 8,000 people. And they're overworked. So how can I support them and maybe walk alongside the people that they have on their caseload and work together and change some stuff. And having those real conversations with Child Protective Services, doctors, nurses, the front desk staff. Also cultivating discernment to understand when we are helping versus hurting. And culture shock here, right? Like everything's different. We have a lot of Alaska Native tribes. We have a lot of domestic violence here, and the drug supply is different than where I was from. So I have to understand all of that and know where it is appropriate to say things or do things before I do them. I have to learn first. So Ashley, I saw there's a huge power imbalance that is used by child welfare workers. Absolutely. I agree. Do you want to expand on that? Let me see if I can find you. Oh, there you are. Do you want to expand? And if not, that's okay too. But yes, I agree. All right, so ethical considerations, again, understanding the cultural needs of the population that you're serving and seeking guidance. I don't know everything. I need to shut up and listen and learn and ask appropriate questions. Some of the folks that I've worked with here in Alaska, I will ask them, like, I can't expect somebody to teach me their culture. That's not appropriate. But I will ask questions like, do you want to share what your rituals and beliefs are? And if they say no, I have to respect that and do my own research and acknowledge that that's the culture, is not talking about it, and that's okay. But I also want to be effective and helpful in whatever way I can. So always balancing the well-being of the parents and of the child, and then asking ourselves, when it comes to ethics versus morals, are they the same thing? So what I'm ethically responsible to do and how that ties into what my morals and beliefs are, do those match up? And if they don't, am I seeking guidance on what that looks like for me in my professional space? Always protecting the person that we're working with and their children. So, any questions anybody has, please feel free to raise your hand and or comments. Thanks. So being prepared, do we know where to refer people to in the event that something comes up that we don't have knowledge on? Do we know where the local harm reduction organizations are? Sean, go ahead.
Is there any way you can give an example where something would conflict with ethics and morals?
Sure. Yeah. So for instance, if I'm a mandated reporter, right, this comes up for me quite often when I was in my doula role. My ethics that I was outlined in the hospital training state that if somebody is using substances, to call Child Protective Services. But I worked in a chemical dependency clinic. Everybody that I came in contact with either was or had been using substances, and now they have a whole child involved if they're pregnant or they just had their child. So I had to set aside what the requirements were, because I'm really here to help that person in that space, and my morals and my beliefs and the understanding of how unfair and stigmatizing our healthcare system is. I had to just differentiate that and make decisions based on that. Did that help?
Thank you.
Let's see, we have Desi said, in case anyone is wondering, the American College of OBGYN does not even support the separation of mothers and their children solely based on drug use. Yes, and exposure. That's awesome. And I've been hearing more and more where this is changing. So so happy to hear it. And also wished I had some of this 15 years ago or 20 years ago, or when I had my daughter at 16, all those things. But we are moving forward with it. So that's exciting to see. So do we know who to refer people to when situations come up, or when it's outside of our scope of our practice and understanding? So for instance, domestic violence. Do we know where the safe shelters are? Do we know if somebody is involved in sex work? Do we know where to refer them to so that they can get what they need? Suicidal prevention. Do we know what to do in a situation where maybe one of our participants is having some suicidal ideation? Do we know what to do? Medically assisted recovery. Do we know where to refer them to if they want to get on Suboxone or Sublocade or buprenorphine or any kind of medication? Do we know where to refer them to? And if not, do we know who to get in contact with to provide that resource to them? The SAMHSA helpline, right? And do they have mental or physical health issues that are being supported? And Do we know where to refer them to that's safe? Do we need to take trainings on any of these topics to further our own understanding and education? And then, are we doing community needs assessments? And I know we're all so busy, and who has time for something like that, but I think when we're seeing a consistent pattern in the population that we're serving, I think it's important to do that and find out what the needs are of the people that are actually living through that, because their voice is what needs to be heard. We could think outside the box of what we think should be happening, but we're really never going to know until we ask the community themselves. So what are some things you all have come across? If anybody wants to share something, we can save that for the end too. I'm fine with that, so you can think about it. All right. I think we touched on this a little bit, but building trust and some strategies for building trust with people who are parenting and using or have history of use, despite the obligations to report. Encouragement and celebrating those wins, right? We talked about that and how important it is to make sure that we see them. We are happy that they are showing up. And we understand how difficult that can be and how much strength that shows. And never shaming anybody, always supporting them. Bye, Mom. Being honest. Honesty is critical in that space. We need to be honest with them. We need to be honest about what our requirements of reporting are. We need to be honest about our own ability to actually help in certain situations. And when we don't know, being able to say, I don't know the answer to that, but I can try and help find something. Okay. Yes, I will definitely share. So also don't try to dictate your intentions onto a person. Again, autonomy. This is their path. Encouraging, understanding privacy and keeping confidentiality for them. We're not, our job is not to discuss it with people that are outside of our supervision space, unless we're needing some support. And also, especially when it comes to some, people who are involved in the justice system, knowing what our requirements are and what we can and cannot share, and making sure that the person that we're working with has a say in all of that. Releases of information. So I think one of the most important things that I can say too is being consistent and available when you say you're going to be. If you say you're going to be there for somebody, be there. And if you can't, have a backup person, a work buddy or another peer that can step up and be available in case you need to tap out. Because like I said, some of this stuff is really, really hard, and we're going to have to process and accept some of the situations that come out of it. We would go to court with some of our clients, and just seeing how they're treated by the judicial system is horrific, even though we know they've done all this work, but they're not looking at that. They're just looking with black and white thinking, which is not. So, and obviously they're gonna make decisions based on their beliefs, and sometimes that can be really devastating and hard to watch, if especially somebody is removed, a child is removed from their parents, and then knowing all the repercussions that come after that, right? It's no longer safe for them in that space. We need to make sure we stay connected with them and know where they hang out. If it's at the local library where they get their Wi-Fi, know what library they're hanging out. So once that child is removed, like, we know how to contact them and try to help find them and keep them connected with services at the bare minimum. All right, so multiple pathways. I want to share with you all what I have. I have a list of multiple pathways and different support groups. And I stole this from my dear friend, Mike Brown, who started Never Use Alone Hotline. And I'll talk about that in a minute. But he put a post on Facebook that said, hey, share with me any support group resources that you know of. Because like I said, when I first started this work, all I knew about was AA or NA. So now I have, I think it's 34 different support groups that I've stole from Mike's post and had some of my own already, but I would love to add to it and share with all of you what I have. But I want to share with you the my list so you can see it, but I also want to hear what you all have, because I know you all have many resources. So obviously AA and NA, and then a little snippet about it that I also stole from Mike's post about a little bit about the meetings and what they entail. So there's some that I never heard of, and I think that it's really important for us to have options for people so they can connect with people that they want to relate to. And I know a lot of times in the judicial system, they got 3 options, maybe. So again, educating the people that that have a say in what the people that we're working with lives entail, and educating them further on the many options there are. So alternatives to suicide peer-led support group. Is that a support group, Brandy? Alternatives to suicide peer-led support group. Yeah, if you guys have stuff and you have a link to it, please share that with me. I would love to add that to this list so that, again, I can continue to share it with others. There's some cannabis and recovery groups. There's also on this list access to naloxone. So it's actually a link to the National Harm Reduction Coalition's map, which I brought up for y'all to see because it takes a long time to load. But it's a map of the US and outside, like we have some in Alaska as well, where I'm at, in Puerto Rico. But if you go on here, it'll show you where all the local harm reduction organizations are near you. Hopefully there's something. We got some blank spaces, but I love seeing this. I just can't even tell you how happy it makes me that we have so many. And so if people need access to naloxone or safe using supplies or connection to services, these are great resources for folks. And we should all have some of them on our resource list. Also, the grief support groups, my friend started SAD OD, which is for people like us in working in this space. We've experienced so much loss that we need a space that's safe where we can process some of that and share about it. So, and then I also included the pregnancy and parenting people, some resources that I'm talking about today, including if you want to become a doula, you can get trained through the Birthing Advocacy Doula Training, or DONA. It's an international accredited doula training and midwives. And the Never Use Alone hotline. Sean, go ahead.
If I recall at the beginning of the training, it mentioned holistic, it was a holistic. Could you explain more what makes it an holistic recovery? If that's what it was implying.
Holistic. So when I said holistic, in working with people, so providing multiple resources around all their needs. So yes, yeah, was that your question?
Yeah, because I would use holistic in like probably complementary, like so I would consider like yoga and naturopathic as holistic as opposed to allopathic. Pharmaceuticals to me would not be. That's just my own personal, my understanding. So I was interested when you said it was an holistic recovery.
Sure. Yeah, and that might be part of it too, right? Like whatever is going to be an asset to them. So that could include things like yoga, Buddhism, whatever it is. Understanding who they are and providing access to or linkage to whatever resources that they are looking for. So all around, I guess is how I view holistic. All around. No end. Thank you. There's also the Brave app, which is something that people who are using can have on their phone. So if they stop responding, then EMS can be sent to them. And I think this is really critical when it comes to pregnant people specifically, because when I was pregnant, sure, I had people that I would use with, but I really wanted to be alone because of the shame and guilt. And, you know, I have a whole baby in my belly. Like, I don't want to use around other people. I already feel bad enough. I don't need to be judged by others. So I would use alone a lot. So having that. So, Sean, go ahead.
I guess, could you explain exactly what makes somebody a doula? What's the training and that as a complimentary? If you can just explain that to me. I've heard that.
Yeah, sure. So doula training is really learning about the birthing process and what happens when you become pregnant, during your pregnancy, postpartum, and all the things in between. So there's a couple of trainings that I linked on here, DONA being one of them. And I think that so for me as a doula, I would work with that person from the time they presented that they were pregnant, which sometimes would be when they're giving birth, because people are afraid to go to get healthcare. But I would work alongside of them throughout their whole, from the time I found out they were pregnant, and educating them on different things, whether it was breastfeeding or getting on medically assisted recovery or getting to support groups, but all things holistically, for me, holistically around, like surrounding all areas of need. And then also being present at the birth and advocating for them in that space. Because a lot of times people who have substance use history in their records aren't afforded the same pain medications as somebody who doesn't have that. And especially when we're talking about BIPOC population, Indigenous folks are less likely to receive appropriate pain relief in those situations. So understanding all of that, what the options are for the birth, and when too much is too much, right? Like there's in hospitals, once you go into labor, once you go at the hospital in Chicago, they had to check on them every 3 hours and move the pregnancy forward. So there's nothing natural about that. So knowing that, understanding it, and being able to educate the pregnant person about their rights and that they can say no just because it's a doctor suggesting that this happens or you know, urging for things to happen doesn't mean it has to happen. So being able to help them through that. So it's understanding all of that. And again, postpartum, at PCC, we would provide postpartum care for, according to our grant, up to a year after the birth. Many of our patients we work with for multiple years, and they're still working with them because it's not just a year. It's could be for some of us lifelong. So yes, and then also on here, and thanks for asking that, Sean. I also included some family support groups. So if you have any resources for that, that would be amazing. And I'm gonna read through the chat really quick. We have a lot. Awesome. Alternatives to suicide. About Us, Wildflower Alliance, Hearing Voices support group. Cool. Yes. I love it. PASS, Pregnancy Addiction and Social Support Program. That is awesome. I know at PCC, we started hosting a support group in the hospital in our chemical dependency clinic for our moms and parents. And it was great to have a space for them where they were safe and they could connect and they could talk about real stuff that was going on in their life. It's amazing because a lot of people don't have any support at all. Smart Dharma, acupressure, yoga, CBT, virtual consumption sites. Huh. Okay. Love it. Thank you for sharing all that, everyone. I love how resourceful you are, all are. All right, and we can add to that list. And like I said, I will add all the things that you all are putting on here to my list and share it out. So I'll just update this. So, providing resources. There's so many options, and I find that a lot of times healthcare providers, judicial, our systems don't understand just how many options there are for folks. So many times when working with somebody who had been reported, I would be told by the child protective worker that they had to do a 28-day program. Well, they have children. Who's going to take their children for 28 days? That's not an option for them. But guess what? There's outpatient, there's support groups, there's therapy, there's so many other options, and they don't know what they don't know. And I understand that. So here we are to inform them and respectfully educate them so that they can do better, right? Especially postpartum, especially if the children are taken. It's so hard for me to keep somebody connected who's lost their child. It is so hard to keep them connected to care and services. And a lot of times I see where they just give up on everything, that they lost my baby, that nothing else mattered, you know, now nothing matters. So it's really crucial to make sure. And then partner care. Talking about the partner, the other person in the room that never gets acknowledged. Many times I would be in the room with a patient who just had her baby, and the boyfriend's over in the corner going through withdrawals, and nobody acknowledged them. And I'm like, why are we not talking to the partner? If we support the family, they have a better chance of succeeding and thriving. Like, but I think people don't think about that because they're so focused on that baby and not the people around that baby who need the support the most. So the Never Use Alone hotline is a hotline where people can call in, and a volunteer sits on the other end of the line. They get their phone number, their name, and their location where they're at. And while the person is using, if they stop responding, the operator will send an EMS to their location. Again, pregnant, using alone. This would have been amazing. And thankfully, the supply wasn't as bad as it is today, as far as what we're seeing with fentanyl and stuff when I was using. Otherwise, I probably wouldn't be here today. But through the Never Use Alone hotline, they were getting so many calls where people just wanted support that it was actually tying up the operators who were there to take those urgent calls of people using and needing that support. So they created Mandy's line for people to call and get just support and maybe connections to resources and things. Again, Mike Brown, amazing. And I will include all those websites as well. So when it comes to legal rights of parents, if somebody is reported to Child Protective Services, do they know what their legal rights are? And understanding the basics of that if we're their support, their coach. And knowing that our role is not to provide any legal counsel, unless you're going for your, you know, to be a lawyer, then we should not be giving any legal advice, right? But we should be linking them with appropriate services for that. And if you can't find any, like in Illinois, we have Prairie State Legal. However, they couldn't handle most of the situations that I was seeing. So we would contact the American Bar Association, and there's a link to that here as well. And that'll take you back state by state, what is in the United States. access to the American Bar Association for each, whether it's a county or statewide, So providing advocacy and empowerment and the importance of that in all of this. And that could mean advocacy could mean a wide spectrum of whether it's having a conversation with a midwife who is disrespecting our participant, or, going and speaking in front of legislators and trying to implement change in laws so that they're effective and helpful. Also understanding the goals of the person that we're working with. So if a person wants to remain united as the family, understanding what the requirements are going to be for them if they get involved with Child Protective Services, hopefully prior to that happening, being real, honest, and telling them what that might look like, because we're going to know all this by now, right? So hopefully we can navigate that together if we don't know, but also finding the people that have the answers to those questions that do know, so that we can be informed and let them make informed decisions based on what the options are. If they do decide to give their child up for adoption, who's a reputable, all-inclusive agency that will work with the participant, judgment-free. For me, when I found the family that took Max, I didn't start looking until I was 8 months pregnant. And had I known that they would have provided housing, food, clothing for me the whole time that I was working with them, I would have done it months before because I needed help. They did end up paying 2 months of my rent for where I was living. And I really didn't want anything else other than my son to have a safe space to thrive. Also, understanding what the abortion laws look like in our state and how we can help if that's their choice, what they want to do. Knowing where to reach out, and Illinois, it's still legal as of now. So, and discussing the plans for their birth. Do they want you there? Do they want an epidural? Do they not want an epidural? Do they want to breastfeed? All the things that if we're not able to talk about and help guide through, making sure that we help them find a doula if that's what they want. And then, again, what does the child welfare system in your community look like? I think we really need people who are calling and being able to support them through whatever the outcomes of that are. Again, American Bar Association. So I don't think we have time for the role play exercise. I apologize because I want to leave some time for questions and answers. But if anybody ever wants to go through a scenario with me, I'm accessible. So just reach out. Just a little recap, active listening. The best way to build trust with somebody is to listen, actively listening to what they're saying and not trying to think of what we're going to say that we have all the answers, because we don't. I don't have all the answers. I just know what I've seen and I know how I can be effective. And that's sometimes just listening, providing empathy, meeting them where they're at and understanding, again, we don't know everything. We don't know everything that they've experienced. The time that we have with them is so short compared to what they're actually living through. And then advocacy, so many different ways to do this. Education and support, not just for ourselves, but also for the people that affect the people that we are working with. And taking those moments where we have an opportunity to teach or enlighten somebody and making that safe still for them too, and keeping all those things in mind. Also follow up and staying connected. Aftercare for that baby is crucial, and especially when the baby's removed, making sure that we have postpartum care for up to years, right? And then providing resources and options. Do we know where to get them? If we don't have them, do we know where to find them? Understanding the requirements of our role, the legal rights of the parents, and the child welfare laws. So that brings me to probably one of the most important things we can do in this space, and that is making sure that we're taking care of ourselves so that we are safe. for the people that we're working with. And that means being aware of our own triggers, our own vicarious traumas, and making sure that we do what we need to do. I've been hiking a lot here since I've been in beautiful Alaska, and it changes everything for me. It can turn my whole day from horrific to, okay, I can do this. And sometimes we do have to tap out. Sometimes we have to say, I can't. And that's okay. We need to listen to ourselves and our bodies, but we always need to make sure that we have people that we're working with, a backup plan for them to make sure that they still get the support that they deserve. And requesting and demanding supervision, at least weekly, because we see some stuff and we need to talk about it with somebody that's safe and that is able to work through and process some of that stuff with us. Because this is hard work. This is not easy. So I thought I'd share this little link I found on how to self-soothe, just some ideas on things to do. I like to give yourself a 20-second hug. It's probably my favorite. Because I never hug myself, but I thought it was adorable. And just taking a minute to breathe and checking in with yourself, making sure that you're safe and that the person that you're working with is safe, and make sure that they're taking care of themselves and that their family is doing the same thing in any possible way that they can. And just loving on people and love, care, and compassion, right? But especially for ourselves too. So questions, and I also, before I get into that, if you're interested and not already a recovery coach, you can contact CCAR. I have their link here. Pregnant Substance Use Toolkit. Dad doula is something new that I just heard of, that if a pregnant person comes in and then their partner wants to know how to support them, then they have dad doulas, which is cool. I just included it on here. I don't know a lot about it, just heard of it, but thought it was cool. And then getting trained to become a doula. Sean, you were asking about that information. There's links to that all throughout this. And this is me. And I'm going to share one more thing and then we'll get to questions. So I also recently submitted a proposal to speak at a call to action to change child welfare. That'll be in October 7th through the 10th. I'm actually doing our presentation on the 8th. It is 2,000 people from all around the world will be there. So we're doing a presentation on how to empower child protective workers in doing their jobs better. Yay. So with that, any questions or comments?
I just think you are fabulous, Michelle. Thank you for making this topic that at times has been difficult to manage my biases with and my personal feelings. As a person in recovery from heroin addiction, I've really struggled at times with just moms using drugs. And I'm going to reach out to you. I'm going to ask for a bit more education and support so I can make myself more available and approachable to other people. So I just really thank you because it's been so good.
Yes, please reach out. Absolutely.
Yeah.
I'll put my email in there in case anybody missed it, but also share the, and if anybody wants the PowerPoint, just let me know. Anybody else have any questions? I know it's a lot. Jacqueline.
Hi. I don't really have a question. I'm just here to echo what everyone is saying in the chat. But also Michelle was kind enough to come and present to a family group that I lead and talk about similar topics, not as extended as this, which I'm sad I wasn't able to make the beginning because of another meeting, but it was really great to have just family members who have someone who might be in active use, or maybe they've lost someone that's really kind of the, I guess, the demographic of our group. And even though they may not necessarily be directly related to this, it was a really great chance for them to kind of like examine their own kind of internal biases and really just get a better understanding of it. Because obviously, I think, well, society's really had us made a gut reaction to automatically associate if someone is using and they're pregnant, like they are bad. And Michelle did such an amazing job, kind of going over that. And then especially talking about all the different, again, understanding if you were to call CPS, on someone, this is what it means. And I think a lot of people who aren't as familiar with this topic, they think like, oh, well, we have to get a kid out of that situation. And so Michelle really did such a great job of kind of breaking down like, okay, are there other ways we can go about this before we get CPS involved? Because yes, maybe there are some good CPS stories. I'm not going to totally shit on them, but I will say like, I don't hear many good outcomes. So I think if we can find alternatives and ways to keep them with their children or whatever it might be, like we have to exhaust every possible option before we bring in any sort of government type body, because I'm not a fan of what the government does. So I just think it's just really great to kind of like have these different conversations. Again, they're hard conversations where, some of us just don't even realize we have that internalized stigma. But Michelle, I just want to thank you for putting this out there. I hope you continue to keep doing this and keep spreading the word. And I love you.
Yes, thank you. I love you too. Thank you so much. And yeah, it is not just, it is, everybody's touched by this, whether they realize it or not, one way or another. And it's important to continue to talk about, so I'm honored to do it. Through that call to action that we're doing, we're going to continue providing education for, I think it's 6 months, to Child Protective Services, and that is 100% free of charge, because that has been my passion since I started as a doula, was to educate and empower them to be able to do what they're supposed to do, which is keep families intact and provide services.
I just want to thank CCAR for giving you the space to have this conversation. And I think you should run this webinar at least once every 6 months and just keep getting more people educated about it. A rerun would be fine with me, because I know I would pick up things I did not hear the first time. So
Thank you. Thank you. Yeah, and thank you, CCAR and Michael, for being here.
Awesome.